Hi, everyone.
Hello.
Welcome. Hi, my name is Valeria. I am the president of Leading Initiatives for Greater Health Transparency, also known as LIGHT. And this is my vice president.
I'm Nikki. We co-founded this organization together last spring. We got approved. We really started gaining momentum this past fall. We got our e-board. We got our lovely e-board. E-board stand. E-board stand.
Stand up.
Yes.
Yippee.
Thank you for all of your help. They're great. It's great to have all of you guys. So basically, like the title says, we are leading initiatives for greater health transparency. We are a health equity organization. If the thing clicks, we are a health equity organization that essentially raises awareness and provides resources for groups that are underrepresented in healthcare. This includes low-income households,
Latino, deaf, hard of hearing, Black, Indigenous. It includes everybody that identifies as a minority.
yes, and especially those who are uninsured. That's a big part of our club as well. And yeah, so we aim to connect at-risk individuals with valuable information and resources while spreading awareness to those on campus in hopes of a more healthcare savvy world. So just to sort of separate our club's mission a little bit more specifically in the fact of raising awareness and providing resources, I would say that tonight is definitely more of a night of raising awareness because as you can see, our crowd is predominantly hearing. So we just wanted to take this opportunity to sort of share the experience of deaf individuals, patients, and providers to all of you guys this evening. So yeah.
Just as a little bit of background on what we do, we normally have GMMs every biweekly. So biweekly, every 2 weeks. Our next upcoming one will be the 21st. So it's normally on Saturdays at noon until 1 p.m.
Yes, perfect. Okay, so just to elaborate on our mission a little bit more, we are going to hand over our mics to Andrea and Madison. They are our lovely event coordinators, and they will explain a little bit more.
Thank you so much. Okay, let's go on to our next slide. So glad to see everyone here tonight. We just wanted to elaborate a bit on our mission and why we think it's so important to hold events like these and why we do a lot of what we do. We think it is super important that everyone, even those who don't plan to go into the medical field in the future, are aware of a lot of the disparities that plague people who are racial minorities and then other types of minorities, those who are disabled, those who are hard of hearing. So it's really important to raise awareness about a lot of the risks and the issues that these individuals face. And Jared, if you want to hop on with me.
Yeah, sure. Hi, I'm Andrea. Nice to meet all of you. So glad to see all of you here. As Madison was saying, we do try our best to raise awareness for everyone that is underrepresented in healthcare. And that obviously needs to start with, for change to happen, we obviously need to start with detecting the issues and trying our best to communicate with those who are the ones that are underrepresented to truly understand what they need and what they think would be best to actually benefit them.
And we hope that you guys leave today with a better understanding of a lot of the disparities that deaf individuals face in healthcare, but then also an understanding on why you should make yourself more educated on a lot of the disparities that other minority groups face in healthcare, so we can all work towards making a more equitable healthcare space. Okay, and we would like to introduce our speaker of the night. Perfect. Okay. Dr. Carolyn R. Stern is a deaf family physician and proudly holds the title of being the first deaf faculty physician, associate professor of emergency medicine at the University of Rochester's 7 urgent care centers throughout Monroe County, which basically means she's been breaking barriers and setting the bar high for everyone else. She's also the medical director and school physician at Rochester School for the Deaf.
She is also on a mission to make healthcare more accessible for deaf patients and to open more doors for deaf healthcare professionals, preferably automatic doors because accessibility matters. With a mix of medical expertise and lived experience, Dr. Stern has a knack for spotting the gaps in our healthcare system and then figuring out how to close them, preferably without duct tape.
Today, she's here to talk about healthcare disparities, but don't worry, she promises it won't be all doom and gloom.
You'll laugh, you'll learn, and you might leave wondering why she hasn't been put in charge of fixing the whole system already.
And we would like to officially welcome Dr. Stern to take over the stage.
Thank you. That was a very warm welcome. So today we are talking about these healthcare disparities. I don't know if you can see me here. I apologize, I'm short. So if anybody in the back cannot see me, wanted to make sure. Next slide. So I have our agenda for tonight. First of why it matters, what is the importance here? And then we'll talk about several disparities. We'll talk about deaf in the medical system, the medical field. So the system itself with deaf patients, and then the medical field. Several journeys I will expand upon, some stories of my own, plus some other individuals' stories. We'll talk about some challenges and solutions. And then we'll have some time for hopefully some Q&A. Okay? Okay, so why should you care about deaf health? Anyone? Nikki. It's a good point. Absolutely. Anyone else? Yeah. Absolutely, good point. We should. We should care about those and all individuals, making sure that health is good for them, making sure that the future for anyone is good. Absolutely. Any others? Yeah. Very good. So, right, we have the right information for deaf and hard of hearing people. We want to make sure that they are included regardless of their hearing status, right? Absolutely. Did I see another hand up over here? Okay, good. So yes, we have some studies that are talk about the disparities of deaf and hard of hearing and also hearing individuals. The findings in these studies are that generally people that have poorer health and have more health challenges to everyday activities and care. So it is worse for deaf people compared to hearing people, and also compared to hard of hearing people too. So like I mentioned, quality of care, it matters. We don't take care of patients, meaning if we don't take care of them, their health suffers. We all, as a community, as Americans, we pay for that, right? If their health is better, we have less costs. Society overall benefits. Medicine is not always serviced well. So this expands a little bit well, like the systemic barriers. It's not just one-on-one with a physician and a patient. It is the overall overarching system that impacts why people get these diseases, how they are able to proceed with getting treatment, how they are provided safety and satisfaction with their healthcare. Mentorship as well for their colleagues. Mentoring and training, education within the system becomes part of the healthcare profession. So again, career promotions, climbing up the ladder in administration or within a university, a hospital, or business. That is all a part of the greater system that includes all these barriers. So why bother? First is liability, the risks, the reason behind why we should take care of individuals and why we should care about deaf patients. We have a law in place, the America Disability Act, the ADA. So improving the quality of care, that means making it better and safe for individual patients. That means the longevity of how they stay in the hospital, how much risk they have for infection, the delays of findings, all of that. Costs and savings. They're decreasing the cost if they're not in the hospital as long. If there's another patient that can move to another floor, that's decreasing the cost. The more a patient stays, the more it costs. Less beds available, less patients that can come in. Costing for interpreting services, sometimes that doesn't all matter, but in general, if they're staying long, they're increasing those services and those costs. So those, like we said, the cost of other things rise as well. And as Nikki already mentioned, a big population here in Rochester. We don't have the exact numbers, but the census and its counting is not, the Census Bureau isn't required the hearing status of individuals to be included. They don't have that functional status a part of the census. So that's where we have to fight to get these numbers to know exactly how many deaf and hard of hearing patients are included in the Rochester area. So what do you know already? We know that most deaf people are very skilled lip readers. How many of you would say that statement is true? Show of hands. Okay, I see a few. How many say no, this statement is false? You're right, it is indeed false. Next, what is the best way to communicate with a deaf individual? I'm going to mention something below. Do you believe it's writing or texting? Do you believe that's a good way to communicate with a deaf, hard of hearing individual? I see a yes over here. That's one way, absolutely. Speaking loudly, do you believe that's successful? Not so much. But I will say for older deaf individuals that may work, that don't know sign language, sometimes that is helpful. But it is always better to choose something else first. Third, working with an interpreter. Yes, do we believe that's helpful? Absolutely. If they are requesting an interpreter, I would say definitely. If they don't know sign language, it's not going to be of a benefit. It's not going to help them. What works best for them? That is the key answer. Did any of that surprise any of you? Yeah? Can you tell me why? Yeah, I will elaborate more on that. Absolutely. That's a good point that you mentioned. If I can hear and somewhat see them, it's good if I know the context of the conversation. There's no music, there's no background noise, the lighting is good. All of that setting is good. The room lighting and everything is right. If it's a dark restaurant, we're in a dark bar, no, it's going to be more challenging, absolutely. Flashing lights, strobes going, that absolutely affects the ability to lip read. So, can you read my lips? We're going to debunk the myth. So about 70% of English sounds is not visible on the lips. So those being loud, those are found in the back of the throat or at the teeth or when the mouth is closed or when people are closing their mouth or depending on how their jaw movements are. That is very variable. Also depending on beards and facial hair will impact. If they have an accent, all of that impacts the ability to lip read. And then about half of English sounds are visually similar. They look the same and sound the same on the lips. I have an example here. Do any of you know what this English word for this sign is? Okay, next one. Do any of you know the English word to this sign? Baby. Say them side by side. Maybe, baby. They look pretty similar on the lips, correct? I have one more. Don't anyone know this sign? What's this sign? That's right. So maybe, baby, pay me. If you look at my lips, they all look the same, correct? Yeah. So that's one example. There are many. This is one of many that we have. So something to consider if you're talking about paying a bill, or if you're talking about a baby, or if you're not sure about a decision, maybe I can apply the context. But if I have no context, it's not going to be helpful to lip read those words.
I have one-on-one conversations with hearing people. I have one-on-one conversations with deaf people, but I do notice a big difference between those conversations. Individuals in the deaf world are very animated, and when I'm having those conversations, I don't become mentally tired. If I'm having conversations with hearing folks all day, I get exhausted by the end of the day. So I enjoy participating in both worlds, and I'm privileged to be able to do that, but not everyone is. Some people feel that the deaf world is better. Some people feel that the hearing world is better. There is a large spectrum, and people fall kind of everywhere on that spectrum. Any questions about this before we move on? Okay. Maybe? No? Okay, perfect. Disparities also include discrimination and neglect. For deaf patients in the healthcare system. So a patient case. This is a story from a good friend of mine about her father. Her father was mentally declining in his age, and this is just part of the bigger story. But I hope that this will still hit you the same. They had a large family meeting, and at the family meeting, the daughter, who was deaf, as well as the father, who was deaf, both participated in the meeting, and the hospital talked to the family and explained that for the whole weekend, they were trying to communicate with her father, and he wouldn't listen. They tried writing on paper, and he refused to listen. The whole weekend, the staff was trying to write back and forth with this patient to get him to comply with instructions. The social worker said, I am very used to people who have different language needs. This patient does not need an interpreter. In the psychologist's report, which was in the patient's chart, he said something about he was a lawyer, he said he was a cop. We thought he was delusional. And that was the diagnosis in the patient's chart, was that he was delusional. And the daughter says, actually, my father was a lawyer, and my father was a police officer, and he was an accountant, like he said. So what do you already notice right now about this story? What has happened so far that you already notice about the hospital system? Yeah. Okay, yeah. Discrimination and neglect. What else? What about people making assumptions about things? Yeah, good one. No communication means stupid, right? Is basically what they're saying. Deaf and dumb, as the term used to be, right? It was much more common in the past. What else do you notice? Lack of patience, yep, definitely. So this deaf daughter explained that her father is deaf and he needs an interpreter. Also, her father has diabetes and needs insulin. In the chart, there was no insulin given the whole weekend and no interpreter provided the whole weekend. Nikki's asking, was this for an ED visit? But no, this was on the floor. I don't know what happened between arriving to the ED and the inpatient unit. I don't know, but this was happening on an inpatient unit. And then often the communication from one unit to another unit is often lacking as well. This was not as strong. This was a hospital in Chicago, so not here. But it happens everywhere. I'm sure something like this has happened and still is happening even in this area. The hospital finally begrudgingly provided an interpreter, and the dementia assessment was completed within 2 hours. And they documented that the patient was uncooperative. There were costs involved, right? Somebody already mentioned, what are some of the costs that might be involved? 3 days worth of writing back and forth fruitlessly, that costs the hospital a lot of money, right? Insurance, maybe they cover it, maybe they don't. Length of stay increased. Patient safety? Was this patient safe if he did not get insulin for 3 days because he could not communicate with the nursing staff that he needed it? A terrible patient experience and some pretty severe legal risks as well. The federal law was violated here. The population of deaf folks is very diverse. There are people that identify as deaf, hard of hearing, deaf blind, disabled, all sorts of different things. If they are born deaf versus whether they become deaf later in life impacts their life experience. Parents, whether their parents signed or not, impacts their life experience. If they went away to a residential school for the deaf, as opposed to being in a mainstream program, that changes their life experience as well. So it is a very, very diverse population. There are also people that use cued speech that are deaf or hard of hearing. Some deaf-blind individuals use what's called protactile ASL, which is really cool if you see it, very impressive. Deafness is a cultural and linguistic identity. I was born hard of hearing. My mom had German measles, rubella, when I was little, and that is how I was born hard of hearing. And for me, I didn't identify as a deaf person until much later in life because I felt like hard of hearing was a good fit. I then lost all of my remaining hearing overnight, and I became fully deaf. And I received cochlear implant, but that did not make my experience similar to everybody else's. We again don't know exactly how many deaf folks there are in the US because the census doesn't ask. So somewhere between 500,000 and 1 million, and that's just in the US. But around the world, probably 70 million folks have deafness or hearing loss. In the US, about 25% of people have some kind of a disability, but only 3% of healthcare professionals have a disability, which means there's not enough of us. Okay. So why are deaf folks called a medically underserved minority? Social reasons include not using English as their primary language. Lots of deaf people tend to end up marrying other deaf people. Their culture is different than that of hearing individuals. Children are often bicultural and bilingual. For example, my 3 children are bilingual. That doesn't apply for every deaf family. Maybe some people are not that bilingual, but power is another one, a lower educational level. Not because they can't, but because the opportunities for higher educational levels are not there. They spend lots of deaf individuals, speech therapists who tend to be hearing people, by the way, will tell parents of deaf kids, don't sign, focus just on talking. And then they learn to use sign language later. A lot of hearing parents of deaf kids are afraid that if they sign, they'll never be able to speak, which is a myth. The important part is the acquisition of language. If you have one language acquired, such as ASL, then you have an easier time learning subsequent languages. Healthcare providers are rarely part of the same cultural group as deaf folks. There are language differences, health knowledge limits and barriers, provide barriers to care. Often deaf folks don't want to bother going to see the doctor because they know that communication is going to be a struggle and they don't want to have to deal with that. Research, again, there's not a lot of data. There is some data, but not enough. And you can see cancer, infant mortality, diabetes, stroke mortality too. There's only one study that studied 6 deaf people that had a stroke. So their experience in this study is 6 people, which obviously is not enough. Have any of you experienced a time where you felt excluded? You can raise your hands. You don't have to, but you can raise your hands if you've ever felt excluded. Okay, yeah. That experience is common. In that moment when you felt excluded, how did that impact your confidence and your engagement in whatever activity it was? Maybe it was you were no longer interested in school. Maybe if you were excluded by friends, you focused on other things, right? For deaf people who are excluded, they can't involve themselves in sports, in higher education, in learning in the future. If they want to learn something, but they feel excluded, it's much more challenging, right? We have that nice buzzword of inclusion, but inclusion really means that people are excluded, right? We already went through some of these different contributing factors. Barriers to communication, barriers to technology, having access to great interpreters versus having access to, good enough interpreters. If you have an interpreter that's in a early childhood education setting, and that's where their sign language exposure is, maybe the language that they have access to is not the same, right? If their parents don't sign, they have that lack of communication. There could be a lot of misunderstandings. Many of you, when you're walking in a building, have masks on, right? That is a barrier. Technology is another thing. VRI, are you familiar with VRI? It's video remote interpreting. So it's where an interpreter is in a call center somewhere in another room or state. And it's a small screen for a three-dimensional language that is put in 2 dimensions. And it is not super easy, right? So also, if the picture freezes or if the internet connection is not great or if it disconnects and reconnects, then that's not really access. Telehealth, there's not enough interpreters available for telehealth. Patient education, lots of the patient education videos that hospitals put out there are not accessible because they don't have captioning or ASL provided.
So again, these contributing factors, we've already mentioned the cultural and systemic barriers. Anyone know what the term autism means? Anyone ever seen this word? Maybe if you've heard the word ableism, have you heard that term? What does that mean, ableism? Okay. So the basic foundation of it is attitude. The attitude that something is better because they can do something as compared to somebody else who can't. Right? So we're talking about someone who has privilege in an area compared to others that don't. So autism is related to the foundational concept of deaf and hard of hearing people that don't have access to sound as compared to hearing individuals that do. So that turns into a bias. It's the same concept as the story mentioned before. We had a deaf lawyer, cop, and accountant that the healthcare system made many assumptions saying there's no possible way he could have been those things. That's a form of autism. It is the negative approach to the situation. So this quote was written by a woman. You may have seen it on LinkedIn or any other platform. She is a deaf-blind lawyer. She has a fascinating story. She wrote a book. This is from her book. It says sighted and hearing classroom in a sighted hearing school, in a sighted hearing society. They designed this environment for people who can see and hear. In that environment, I'm disabled. They place the burden on me to step out of the world and reach into theirs. Think about that for a moment. That is quite powerful. She's telling a story that you have different chairs, right? All of you are sitting in different chairs. You can buy different chairs. You can buy beautiful chairs. We can set up lights here in a beautiful room, lots of colors. She says, I brought my own chair. I don't need the lights there. It's not helpful for me, but it helps others. But if roles are reversed looking at me, I'm now the problem. So it's a little fun, ironic. This is by Haben Girma. So we have a cultural model and we have the medical model. Is anyone familiar with the cultural model of deafness? Anyone? Anyone guess what the medical model is for deafness? Hearing impaired, quite often, yes. What else? Something that needs to be fixed. This is the focus. The ear that can be fixed, that means we can be solved, or we can be fixed and anything can be solved. But maybe that doesn't mean we need fixing. The cultural model says that if you acquire language, you can be successful. Language is the key to success. The medical model looks at the ability to speak and hear. That's what leads you to success. They don't look at the language part. The deaf cultural model is labeling the deafness as a big D, and the medical model is labeling it as a little d. The issue for the cultural deafness model is that the environment is not accessible. For the medical model, the hearing loss is identified as the problem. So that's the difference. So you have to think about deafness as a deaf gain. Many deaf people think that it is a deaf gain. That means as a deaf person or a deaf group of people, they can provide society with many innovations that everyone in society can benefit from because it came from deaf individuals. One example is how many of you have watched the film or have scrolled on your phone with captions? Have any of you watched with captions? Oh, wow. Okay, so that's like 80% of you who watch with captions. And can someone tell me why? Okay, good point. English is not her first language, so she's reading the captions to help understand. Anyone else? Why do you watch with captions? Ah, okay, a different way of learning. Absolutely. Anyone else? Yeah. Okay. So things that are missed, you are able, hearing individuals aren't even perfect at hearing things. I think there was a hand in the back. Yeah. Okay. It's fast reading, then just listening to it slower. Okay. Good points, all of you. Also, maybe you don't want to wake up maybe a partner next to you with the sound, or you have a kid in the room watching something. Right now, sound in movies is very distorted with a lot that is going on. Overlapping of sounds and things happening. It's hard to hear and distinguish. So that is an example of a deaf gain that is benefiting the hearing and overall general population, people that are watching captions on TVs. That was back in 1976 that happened. There was a big fight for captions to happen, but that's a huge gain for all of us, correct? How many of you text your friends instead of making a phone call? Deaf community. Football. Did you know that the huddle, do you know where that originated from? Gallaudet University, the deaf university in DC, because they didn't want anyone outside of the huddle to see them signing, so they would huddle. But that has turned into a football tradition coming from deaf gain. So think about it for a minute. These are things that stem from the deaf community that gave value to everyone. So it may have opened up your mind about some things. People more so in the deaf community use their eyes and the visual system more than anything. So this image is from a deaf artist. I can't remember who the artist is. I apologize. Please forgive me, but it is from a deaf artist. They themselves were they were very interested in making the word water spoken, and then the child received a prize for speaking clearly. Instead of focusing on the language itself, signing maybe instead saying water, please. So the medical profession, we use this word, hearing impaired, deaf mute, or deaf and dumb often. This is from another deaf artist. And now the cultural terms that are appropriate in the cultural deafness world are deaf, hard of hearing, and an individual with hearing loss. How many of you know ASL? Okay. ASL, American Sign Language, is a 3D language. A woman who is deaf and did a TED Talk. I think her name was Kim. She's an artist, I know that. And she described ASL like playing a piano. She described that every finger that you play on the key is represented as a sign based on how each finger, so for example, one finger would represent facial expressions, one finger would represent finger spelling, one would represent speed, one would represent body movement, all the different parts of ASL. And if you change one finger And one key on the piano, that changes the entire meaning of the entire phrase. So if you are hearing, you have a voice change. So that change can be modified in the deaf culture, like this, saying, I'm sick. Or I feel so sick. Ugh, I am on the couch all day, exhausted. So how you change one sign to another changes the entire meaning. Sick is a sign, but how you sign it is how you change the meaning. And that affects the language. Medical lingo, for example, my interpreters, my colleagues, my deaf patients, people who interpret for deaf patients know the medical vocab and jargon. They are not thinking it is English, it is ASL. For example, the sign to run. To run, my eye is running, my nose is running. I'm running a machine. The various meanings for the word run have different signs in ASL. Medical English, one example, the word prom. When people hear the word prom, what do you think? You think the dance, right? The high school dance, prom. Okay. But in the medical vocabulary, that does not mean the high school dance. That means a rupture that has happened to the amniotic sac. The woman's water has broken, and it happened early. That is the meaning of prom. It is an acronym. Cervical. It means the neck, yes. But there's different locations of that area of the neck. The cervical spine or the actual cervix. So those are very different areas of the body. But if you're hearing and you hear cervical, the first thing that you think of may be the neck. But we would actually be talking about somebody in doing an OBGYN exam. We're not looking at the neck, we're looking in the pelvic area. Dressing. We're not talking about getting dressed. Who knows what a medical dressing is? Yeah? Good. It could also mean what? A dressing on a salad. Absolutely. Dressing. That's not what we're talking about here, but that is a dressing. This is a medical dressing. One last one. Cabbage. You think cabbage, the lettuce, right? Wrong. It is a medical acronym meaning coronary artery bypass graft, CABG. Cabbage. It's hard for the interpreters too. You're not the only ones.
So I'm going to give a little bit of a story, hopefully briefly, about myself. Can I go to the next one? I advocate for deaf and hard of hearing patients, colleagues, and I also work with interpreters to make sure that they are able to increase their vocabulary. And I also am a mom and a grandmother too. I have a granddaughter. I am the only deaf person in my family, which is very common. My parents are hearing There are no other deaf individuals in my family, and none of them know sign language. My husband's parents are deaf, so he has a very different view on things. I grew up in the hearing world and as a deaf person, but he grew up in the deaf world as a hearing person. And our cultures are very different, very different. So sometimes that communication is, at the beginning of our marriage, we had to learn how to communicate with each other. He was very blunt, and I usually kind of beat around the bush a little bit, like hearing people do, like, hey, honey, it would be nice if you wouldn't mind maybe doing, and he's like, just tell me, go do this. So very different. But we worked it out. It's been, I don't know how many years, 30 something years at this point. So just a little bit about my story. I went to Northwestern University in Chicago for med school. Lucky me, I got in after I applied to 17 different med schools. I was afraid that I wasn't going to get into medical school, but luckily I got accepted to 3, one of them being Northwestern that I went to. There was a special system called medical notes. So I would record the lectures every time that I was there in the front of the classroom. I had an FM system as well, which is where the instructor or the the instructor or the professor, like in a football stadium, would have a mic on so that I could hear straight to my hearing aids while they were wearing that. So that was super nice. I also got free notes because I recorded all of the lectures. So that was nice in medical school, but Northwestern, they started providing interpreters, but then later realized how much money it costs to pay for interpreters. So after 1 semester of interpreting services, now keep in mind this was quite a long time ago, how much do you think 1 semester of interpreter services cost back in the day? Just give me an estimate. $900 is actually the answer. $900 for 1 semester back in the day. So I'm like, okay, you've already said that I can become a physician, so you can't deny me access services. I ended up suing Northwestern, and we settled it outside of court, but that was a big deal for individuals with disabilities. My family medicine residency program at Lutheran General Hospital. It was a family medicine residency. The first, during this second month was all overnights. And in the morning, I was given report about all of the people who had come in overnight. They would tell me, their story, why they came in, what their chief complaint was, their labs, etc. And during that report meeting, I didn't hear anything. And I'm like switching out my battery of my hearing aid. I'm, changing my stethoscope battery. I couldn't hear anything. And I went down to audiology and I found that I had become fully deaf overnight. So I was hard of hearing and I could hear, relatively well. But in, an instant, I was deaf. And I took 2 weeks off of work, but then I went back and things were up and down. I did get a cochlear implant. And, then things changed, but that was my experience. I graduated medical school. To stay and become a physician, you needed credits. You needed medical education credits, ME credits to get and keep your license. And if you don't get the credits, your license would be revoked. So I tried to go to 2 different big conferences. I requested interpreters, and they refused to provide interpreters. So the Accreditation Council for Continuing Medical Education, I said, if you are approving this course, you're approving this program as a program that they are allowed to teach to physicians to get and keep their medical licenses, you're telling me that I cannot stay a physician in the US because you won't provide interpreters, which is illegal. So now I present all over the US talking about ADA and how you are required to provide interpreters and access services. So anyway, okay. What do you know or understand about the term deaf tax or disability tax? Is anyone familiar with that term, sort of? Okay. So it means that basically I have 2 jobs. One is the job that I was hired for as a physician, and the other job is to confirm and make sure that I've got an interpreter there, to confirm and make sure that there will be captions in the videos, in the trainings that I have to take, send information about diet, or I don't know, information about, where do I need to sit, and I need to make sure that I'm in the front so that I can see my interpreter. All of those things that I have to think about and plan for my own accommodations is my second job. Working at U of R, that tax is still there, but it's much less than it was and has been at other places. We now have leadership and representation in administration here at the U of R. I'm running a little late on time, so I don't know if I have enough time to share my experiences as a patient. So that'll be a story for another time. But it is important for my survival and my success is humor. So technology, there's Bluetooth. I can hear patients' heart through my cochlear implants with a Bluetooth stethoscope, which is really cool. There also are visual cues. If I'm working one-on-one with a patient, then I can understand them. There are clear masks that have the mouth showing. Technology has helped for sure. Former First Lady Nancy Reagan, former fertile lady back in the day. And then you can see Spock sobbing mathematically here. Again, some humor. I'm just going to blow through these. I think it's important to understand that working with interpreters does not always solve the problem that you're trying to solve. As a physician, I am responsible to make sure that my patient understands the information that I'm giving them. So I might have them do a teach back. Okay, I just gave you these instructions. Tell me what I told you, so that way they can say it back to me and I know that they've understood. Some deaf folks or some situations need a deaf interpreter, a certified deaf interpreter, which means a deaf person that is an interpreter themselves. So like you can see here, there's a hearing interpreter in the blue that is communicating what the hearing person said to the deaf interpreter in red, who's then communicating to the deaf person, the deaf patient, and then vice versa. It might take a little bit longer, but it makes for more clear communication. There are some individuals that have home signs. For example, my sign is white, but maybe they point to their tooth to mean white. You don't know For example, if they're talking about what color milk they drink. What color milk do you drink? Oh, I drink the blue one. Depends on what their home milk is. Is it 2% that's blue or is it skim? Appropriate care is not provided if only the language is interpreting. There's a lot of culture, there's a lot of context that you can miss the story in. I work with what's called designated interpreters, which means that I have interpreters that are familiar with and skilled at working with me in my career. If an interpreter doesn't know enough medical information, they don't know enough vocabulary, they don't know enough context, then they might not be a good fit to work with an urgent care doctor. They need to have some of that familiarity. They spend, hours and hours every week. I work 12-hour shifts and I have an interpreter with me. I need someone from 9 a.m. to 9 p.m. Or later, so it's a long day, but they work with me for an entire shift. If you're interested in doing research on the deaf community, I would say that Rochester is a great place for it. We've got a lot of resources. We've got a lot of programs for deaf and hard of hearing folks, a lot of programs for deaf research. We've lost some funding, unfortunately, during the recent times, but we did get quite a bit of it back. Unfortunately, not enough, but there's lots of opportunities for research.
This is a great video here about deaf patients in the healthcare system. Again, there's a diverse group of deaf patients. I'm not going to have time to show you now, but this is a fabulous video to watch. So I am going to pause now because really the point is the solution is there's not enough time for everything to be said, but I feel honored to be here. Are there any questions? I want to open it up to the audience.
Sorry, just in our which you guys will all receive, I can link the video in there so you guys can watch it.
Thank you, Nikki. Any questions?
You work with the Rochester School for the Deaf.
Yes.
I took classes at RIT and TIE. I took a semester of sign language, and it was conveyed to me at the time that the residential schools, while they had a bad history, there are also some very good aspects we may not realize. And one of them was that it allows the students who come in to gain a culture and also a language, especially if they were not. Is that your experience with them?
Yes, it is. We have some students that require to stay at the residential school Monday through Friday. Weekends, they go home, but that is because they do not have communication access at home and or because of the distance. It's unfortunate that a few of those students, their parents do not support them. Maybe grandma and grandpa are who takes care of them. Maybe they are in the foster care system, or they are in an abusive situation at home that creates many challenges. About 30% of those students have deaf parents, so their language is there. But to those many students who go to RSD, they show up without language and they are taught there. Many of them come from other countries. They move here to the US because the US offers language access at these deaf schools. Other countries they do not have the access services for deaf and hard of hearing children that we have here. Many of those parents are very motivated to come here and find work and find access for their child, but unfortunately it gets delayed. Some of them don't show up to school. They're maybe 10 or 11 years old and now just learning language. There's a lot for them to catch up on, which is a huge challenge. So you're absolutely right. There's a whole gamut of experiences with these students. It's a good point. Please, yes, it's okay. I'm not a scary green monster. I hope not, at least. If you don't want to, I'll stay up here. Oh, yep. Improving what exactly? Improving the deaf accessibility to the healthcare system? Okay. Um, that's tough. I think it's a big one. Access to good education within the system is key. If we can provide that education to the community and we don't have to require English and the ability to speak fluently in that language, I think that we would be much more successful. There are places in the world where people do sign regardless if they are hearing or deaf. There's a place, there used to be Martha's Vineyard. If anyone is familiar with Martha's Vineyard, it used to be a very big signing island, 60s and the 1960s and 70s, where regardless of if you were hearing or deaf, it was a place that you signed. I think near Bangladesh or Bandora, the community village there, it was an Arab village in Israel, same type of deal, where the whole community knew sign language. And they all thrived because, again, it was helpful for everyone. At RIT, there is a chemistry student, a professor who teaches sign for the different chemicals and molecules. And also it is for the deaf and hearing students that all thrive in that class because it's visual. You can see the shapes and sizes of the molecules, like that molecule O with the ring, benzene rings, all of that. It becomes a visual, this is just one example of the different shapes and sizes and things that happen in that class with the chemicals. But with the combination of the language, it's accessible for everyone. So there is places where it's possible. Education, I think, is the key, though. Everyone should learn ASL now. Come on, that's my opinion. When you get older, and everyone is going to have a little bit of hearing loss, right? So something to think about. Yeah, oh yeah. So in Chicago, there are many deaf individuals who are from like Mexico, Ecuador, Guatemala, and they have their sign language, which looks different. And I have visited other countries like France, Japan, China, Israel, and all those different countries have their own sign language. It's not ASL, but Italy was another one. We had a team of team physician in Italy who went to the Olympics, and many of them learned the gestural or international sign language, which they do. We do have international sign language. It is a thing, but it is not where every country and everyone knows international sign language. again, because the sign language is culturally related to the country and culture it is from. Like Mumbai, would they sign Mumbai? We don't sign that here. I'm trying to think of another example. In France, they sign for the train, because they have the actual rails up in the air that looks like a cable car, and that is their sign because it is a visual representation to the concept. In America, we have the train tracks on the ground, so we sign train like this. But in France, it looks differently. In Japan, they sign train because it is the shape of the front of the bolt train that goes fast in that country. So that is train. That the Japanese word for train is also different. So this is what their sign is. So it's culturally based and dependent, again, on the environment of what is happening in that country. In England, the sign for T, it's not T. We sign T here. In England, they sign T. Because the pinky up is a cultural thing, and it's a cultural significance for that country. So again, there's no one language or one sign language. English, Spanish, French, spoken languages is the same thing. Different countries have their own spoken languages. Same concept with sign language. Yeah. Again, it is based on the country of where you're growing up. Why don't we all know? There is a universal English, quote unquote, right? Why don't they teach that in the schools? Same concept. Where you're growing up and where you're raised, the culture and area that you're in is the language you're going to learn. Maybe some more than others, in a general community, but often if you are in a type of melting pot together, maybe you're playing different sports and activities and mingling with different events and quite diverse other people from other countries. Like now you can watch videos, and like right now I'm watching videos from BASL, other countries, their sign language. But one nice thing is that if I'm deaf and I go to another country and I don't know how to communicate in their sign language, and I want to find the bathroom, for example, I might do something like this. They might know and be able to pick up, oh, she needs to go to the bathroom, and direct me in that way to the bathroom. Because we have found other ways of communication as deaf individuals. Nikki is letting me know time is unfortunately out and we can no longer go further. I want to say thank you all for coming, and make sure you send them my slides, right, Nikki? Thank you all. Thank you for your time.
Thank you so much, Dr. Stern, and our interpreters, Sarah and Lauren. We want to thank you guys for coming. This has been our first sort of big event that we've done, so it's really nice to have your support. If everybody if everyone was signed in, you should receive our summary email, and we'll send the links there. Thank you again, Dr. Stern. Give it up for Dr. Stern. Thank you.